Thank you very much, ma'am. Without much ado, I would quickly run through the program for today so that we have an idea of all we'll be doing. So our first speaker would be Dr. Oge Ilegbune. She will be joining us and speaking. Also, she will speak for 30 minutes, and then we'll have a 20 minutes question and answer with her. After which Dr. Aina would be introduced for our presentation for another 30 minutes, followed by question and answers too. And then that's it will run from 11:30 to 11:50. We'll have a short 5 minutes prayer time by Mrs. Okoduga. And then by 11:55, we'll have the vote of thanks and closing prayer by Mr. Bolarua. So by 12 noon, we should be rounding off this meeting by God's grace. So without much ado, I would like to introduce to us our very own doctor in the house. This is Dr. Oge Ilegbune. A quick introduction of who she is. She is a graduate of the University of Nigeria, College of Medicine, completing her residency and qualifying in general practice in the United Kingdom. She's a medical director at the Lakeshore Cancer Center with its patient-centric ethics in its delivery of cancer education and screening, diagnosis, treatment, palliation, research, and philanthropy. She's a lifelong learner completing certificate program in healthcare management, healthcare financial management, leadership and management, and also project management. She'll be speaking to us today on the topic Women's Cancer Screening 101. If you can do your icons, your emojis, so please welcome her with a clap offering in your reactions if you can. And if you, let's welcome Dr. Oge. Welcome, Ma. Please, you have the mic.
Good morning. Good morning. Thank you very much for having me here today. It's a real pleasure, and I'm excited. Having spoken with your men folk last week, and that was fantastic. The turnout was great, the engagement. Even more excited to be amongst my female folks, and hopefully this will be engaging. This isn't exactly a lecture, and I don't want to assume that some of the information I'll be sharing, you've not heard. More, I think it's a reminder, a refresher, a clarification, and then a few new bits of information. And Abiola just said something that we are here to be informed. And the truth of the matter is really an excuse anymore in this 2025, because things have changed. I moved back to Nigeria in 2014, and I remember the first 3-4 years while Lakeshore was trying to build on their education and awareness culture, that it was tough. People didn't even know what we were talking about. But now, in 2025, people are actually engaging us and saying, when can I come for this? Or I heard this. So I just want to say that ignorance is not really an excuse anymore, because there are lots of these talks being organized, whether it's through the churches, through the mosques, all the different religious organizations, through work as well. HMOs are even organizing these ones. And then friendship groups, you have friends coming together and getting someone to come and speak to them during their social outings. And then, more importantly, I think we have all been impacted by family members and friends and colleagues who have also gone through the cancer journey. So again, I just want to say ignorance is not really an excuse anymore. it's not really a case of it's not my portion. I think we need to be balanced with our faith and our medical knowledge. So I'll just share my screen now. I just wanted to say that because Abiola started it. Okay. So please let me know if you can see my screen.
Yes, we can, ma.
Yeah, I'm just trying to put it on slideshow.
Okay.
Okay. All right. So when Biola asked me what my topic was, I said, you know what? Cancer screening 101. We're not here to talk about the treatment of cancer or the epidemiology of cancer, the sort of conversations we'll probably have in the classroom or within the medical group. This is just a refresher. So I just thought 101 has always been known to be the basics, the foundations. And again, the theme, health is wealth, is an amazing one. And I commend the ICOC for coming up with it. Because without your health, how can you make wealth? And we're not just talking about financial wealth, right? It's wealth on all different levels, the wealth of friendship, being able to engage with people, your financial wealth, the wealth of being able to do your work, the wealth of being there for your family and for your friends. So without good health, this wealth is a struggle for all of us. If you've even had malaria for 3 days or a chest infection, you know how this is. When everybody was falling ill with COVID, it was terrible. So you can imagine a society where everyone is unwell. So we want to be healthy. So I just want to share a few facts about women's health, and possibly Dr. Aina will also be taking all these other bits, in greater detail. I want to mention that heart disease is the leading cause of death. Is the most common cancer. I don't think the breast cancer one is a surprise. We don't even need statistics. If we start counting all the people we know, and you think of all the other cancers, you know that breast cancer is actually a very common cancer. And then menstrual health, menopause matters. If you're looking at me now, you probably see me sweating. This has nothing to do with the fact that this room is hot. I have 2 air conditioners on right now, but I'm still sweating. So menopause, very important for those who are, from their mid-40s and above, even though we have some women going into premature menopause from their late 30s as well. Mental health, we now know, is as important as physical health. About a decade ago, or maybe even longer, 15 years ago, mental health was not discussed. It was very stigmatizing. People didn't want to, even if you were feeling depressed, you had low mood, you were anxious, you didn't want to talk to people about it. Now we know that the tide is changing, and the WHO definition of being in good health is not just saying physical health. So when you don't have a fever, you don't have a headache, you're able to move around, it doesn't mean that you're well. Sometimes you suddenly hear, oh gosh, that person collapsed, or this happened to the person, or suddenly the person was admitted for their mental health. But everyone's saying, but I saw that person moving around. So the fact that somebody is moving around does not mean that mentally they are well. Then another one that, jumps up is osteoporosis, which affects millions of women. And I know we know more about arthritis. Everyone know your joints. Oh, my grandmother had it. Oh, I'm getting arthritis, my shoulder, my knees. But little is said about osteoporosis. And yet, many of us will develop osteoporosis. Then, sleep deprivation affects hormones. We know that. So if you're getting a certain number of hours less than you should, Please be aware of this. And then something that we know is that nutrition is key. Fueling your body. What you eat is what really drives your body. That's what you use to metabolize everything that you're doing, that happens within your body. The right nutrition is key. So, very briefly, and I'll explain why I'm touching on this, that the risk factors for heart and cardiovascular disease really is linked to the risk factors for cancer. So the more you are warding off heart disease, the more you're warding off cancer. So what's heart disease? Blood vessels being blocked and narrowed. That essentially, that is what it is. And the risk, the things that would lead this to happen would be things like high blood pressure, hypertension, high cholesterol, bad fats in the body, smoking, lack of physical exercise or physical activity. We're not even talking about exercise alone. We're talking about the ability to move. So these days, thank God for virtual, COVID brought that, but now we're sitting even more. We're in front of our gadgets. You go to work, you don't get up. People are complaining of their back, complaining of various pains, and that's because we don't have physical activity. And in our homes, there is a cultural trend. You have the housekeepers, and so they go, you tell them to go and get you water to drink. Meanwhile, the kitchen is round the corner. You tell them to go and pick you your remote. You tell them to go and warm your food and present it to you on a tray. And yet, you're in your 40s, you're in your 50s, you're even in your 70s and able to do those things. So those reduce the physical activity. So as your housekeeper is moving around, they are fit. They are adding to their years and their lives. And you are seated and telling them to go and get this and that. And you're adding, problems to your years as well. So this is even before we now start talking about exercise. So this is physical activity. Diabetes and obesity, most of us are overweight because of our, whether it's the way that we are made or the way or what we eat, the things that we eat. Our diet in Nigeria is carbohydrate heavy. And so we are overweight. What you eat is what you see. Then family history plays a role. You need to know yours. Family history of heart disease. So when you come to my clinic, I have a template that I use to get history. I actually prefer taking history from my patient rather than having a junior doctor do it for me. But even if they do, I go through it again. And the whole idea is there are elements in that history that, they are key. Family history. What is going on with your father and your mother and your siblings so I would ask, do you know if there's hypertension in the family? Do you know if there's diabetes? Do you know if somebody died of a heart attack? Do you know if there's cancer? You might not know, but what I always say to people, if you still have living members, your father, your mother, or your siblings, have a conversation and know your risk, because that adds to your risk assessment, risk stratification. If you tell me that you have a family history of high blood pressure, and then on the day you come, I check your blood pressure and it's high, and then you go away and do some tests, and your cholesterol is raised and your blood sugar is high, already your risk of developing all sorts of heart diseases is much higher than someone who has no family history, who doesn't smoke, who is exercising, and who has no blood pressure issues. So please know your family history. Know the family history of cancer as well. We need to start talking about it. If you have siblings, when you have your family meetings, don't talk just about the problems in the family. Ask each other, how is your health? What do you have at this point? Then lifestyle measures and medical treatments are game changers for heart disease. Lifestyle measures. It's important to know that 1 in 3 women die from this preventable condition. And when I say 1 in 3 women, currently, I don't know how many women are on this call at the moment. And, I would say, God forbid, but what it's saying is that if you take 1 in 3 of us just do the maths for the accountants here. You would see that at least 1 in 3 of us is already heading to this sort of condition. Now, osteoporosis, very quickly. What is osteoporosis? It's a condition when the bones weaken, they become brittle, they become fragile, you lose strength, you lose bone density, and then you become prone to fractures, pain, mobility issues. And it's a silent disease that progresses without symptoms until you have a fracture. And 1 in 3 women 50 years and above will experience a fracture from osteoporosis. Because what happens in menopause, so for those of us now who are in it, perimenopause, menopause, you're already losing bone mass. You begin to see our neck. You notice you lose that roundness you had around your face, your neck. Suddenly you see your friends that you haven't seen in some years, and you suddenly realize we are aging. What it is you're also losing mass, bone mass. And then as you get older, you also see older women who are becoming hunched. I don't know if you notice that. You're losing bone mass. That first 5 to 7 years of menopause, you are losing bone mass. And some of the risks, menopause, lack of exercise, smoking keeps coming up. And I know people say, I don't smoke. You know, culturally, Nigeria, we don't smoke. But actually, can I be honest with you? Judging from my conversations with women during the clinic, women in Nigeria smoke. And then low vitamin D and calcium. So weight-bearing exercise is key. Thank God for YouTube now. Thank God for online searches. You can find things on your phone. Find out what weight-bearing exercise is so that you can understand what to help you with, maintaining your bone mass. And so, back to cancer. What is cancer? Like I was describing to the men last week, just imagine you're driving a car that has lost all control, the brakes. You're pressing the brake and nothing is going on. That is actually what cancer is. That is what happens. So the normal cell cycle, for those of you who might have done science, you have the cell, the growth, then it dies, and the whole cycle begins. I mean, it's even the same cycle of life. You're born, you grow, you die. With cancer, that cycle is disrupted. Something happens, various factors happen, that means that you lose that whole cycle of growing and dying. So you have uncontrolled proliferation. These cells continue to multiply and multiply. And in some cases, you notice it as the lung, a tumor, and then it begins to invade the tissues around where the original site is. And then it spreads to other parts of the body. So giving an example, if it's a breast cancer, for instance, initially you will find that lump within the breast, but suddenly you find it around the chest wall. Then suddenly you find it inside the armpits, the lymph nodes. Then suddenly they'll say, okay, you have it in the liver or in the lungs or in the spine. This is what happens. It's uncontrolled. And the whole idea for the doctors, the oncologists, is to stop this lack of control. And so we have stages 0 to 4. And the reason I'm talking about the stages is that when we come to screening, we want to screen to detect the earliest cancer possible or abnormality. So the whole idea of screening is that you hope that when you screen, there's nothing. But that if there's going to be something, because you are regularly screening, you want to get it as early as possible. And so that's stage 0. When you check and it's only abnormal cells. It's not actually a cancer at that point, but you can see that something is going on. The doctors love this stage because you can almost guarantee 99% cure rate. Nothing is ever going to happen to this woman. You're not talking about recurrence. You're talking about complete elimination. Now, stage 1 is you can actually now see that there's a cancer, but it's localized. So let's use breast again. It's just there. Nothing. It's not in the armpit. It's nowhere. Nobody feels unwell. You do the scans. There's nothing. Then we talk about stage 2. It's now gone into the lymph node. So when you check, you can see, right, the lymph nodes have some cancer cells. And the thing with the lymph nodes, they're like a channel through which, materials are exchanged from one part of the body or the other. So once it's in the lymph nodes, you're kind of worried, right? We must halt it here. We don't want this going anywhere else. So that's a stage 2. And then stage 3, where it started going to other tissues. So, it's in the chest wall, depending on where the cancer is, it's in the tissue surrounding it, whether, it's in the peritoneum or, different parts. And then stage 4 is when you can see it in the liver or in the lungs or in the spine or different areas. So the whole idea of cancer screening is that if there is something, we want to get it early. We want to start early to screen. We want it to be regular so that we can find it as soon as possible. And so again, like I mentioned earlier, risk factors for developing cancer is really pretty much the same as the hypertension, diabetes, because they're all linked. So family history, like I mentioned earlier, and genetics, if you already know, oh, okay, there's a family history of, let's use the men, for instance, prostate cancer in the man, then he would say, okay, I better find out, did my father have it? Did my brothers? When you have that sort of history, you know that you must be checking regularly. The same with breast cancer. Of note, not all cancers are inherited, so it's not all. But for those that are inherited, you need to ask questions. And then there's also genetic testing to be done. Then obesity, this whole idea that we're overweight is a problem. Obesity encourages fat cells, which become, length and increase the risk of cancer. Alcohol, I think we already know that. Smoking, again, sedentary, lack of activity, lack of movement, and lack of exercise. Poor, unhealthy, unbalanced diet. So you might be eating a lot of food and it looks rich, but actually the content of it is poor. So you might be eating and the food looks plentiful, but the content of it is poor. So if you remember that whole nutrition plate, what should be in different portions, we already know that things like proteins are good, vegetables, fruits, but carbohydrates should be minimal. Oil should be minimal. And that is exactly what we should be doing. But you know what we do? We have a big plate of rice, white rice, with stew, and a little drop of coleslaw. Remember, that coleslaw already has been mixed with a lot of cream, which is already unhealthy. And then you have plantain, which has been fried in oil. And the food is big, and you eat it and you're full, but actually you're stressing your body, you're stressing your system. The ideal thing should be that you have a significant amount of protein there, a significant amount of vegetables, whether it's in salad form or steamed vegetable, then you have a little amount of the rice. So the rice is not the main meal. These other things are the main content, and the rice is just a bit of carbohydrate to convert to fuel in the body. That is actually the way we should eat. And, trying to remember years ago, visiting my grandmother in the village, the food, it was always, whether it was okwa, whether it was vegetables, mixed with the plantain, whether it was there are all words and names of food that don't even exist anymore. Pure, just different things. And I'm sure this is a multi-ethnic group. So I'm sure we all have those different recipes in our own areas of Nigeria that we used to eat that have disappeared. Now, if you open the fridge, there's stew, jollof rice, what else? That's it. Sometimes people are even bored of what to eat. And yet, we have lots of food in this country, lots, nutritious. So sometimes when we even say that Nigerian food is carbohydrate heavy, I actually am speaking of the present. It's not of when our grandmothers were cooking, or even to a certain extent, some of our mothers. we have not always been a carbohydrate-heavy country. And then add the whole idea of the fast food. People are going, let's take Lagos now. People leave early for work. People come back late. It's so easy to tell the housekeeper to stop at Chicken Republic, pick up some, fast food for the kids. We ourselves, we even eat it as well. You're too tired, you come back. Is there any chips left from that Chicken Republic? So our diets, we have gone into the Western way of eating. And sometimes when we say that our children are picky, oh, mom, I don't eat this, I don't want this, I don't want that. It's actually a function of what we have presented to them growing up. And then we have infections as risk factors as well. HPV, human papillomavirus, HIV, and hepatitis. These infections can cause cancers. And when we talk about cervical cancer, we will talk about the HPV. For the HIV, the sort of cancers will be things like lymphomas, Kaposi sarcomas. These are linked to having HIV, which is why when women have HIV, we have to screen them more regularly than the average woman. Hepatitis B and C is endemic in our country. Some facilities, like in the medical profession, all of us are vaccinated against hepatitis B because you can pass it on to someone else, to a patient. So one of the credentialing that is done after you have your license is, please, can I see your hepatitis B certificate? So whether you're a nurse, a doctor, a lab scientist, as far as you're going to be handling fluid or exposed to body fluid. Hepatitis is endemic. So we encourage everyone to get their hepatitis vaccination. And then the other carcinogens in our environment, I don't know how many of you, sometimes in the traffic, you're behind one danfo, and the kind of black suits that will be coming out of the exhaust is just unbelievable. And then certain radiation and dye as well. So cancer screening, and the reason I want to sort of define this is that sometimes people are a bit confused. If you have a lesion, you notice something that is wrong, and you come to the doctor will not be doing screening. The doctor will be doing diagnostic because you have already come with a problem, and the doctor's role is to find out what is this. But with screening, you are testing an asymptomatic population. In other words, you're healthy. There's nothing, you don't have a headache, you've not noticed any lumps, you have not noticed any bleeding. All it is that you are being a good human being and going to have your regular check. That's what cancer screening is. That's what blood pressure screening is. That's what diabetic screening is. When your HMO gives you a list, or your doctors give you a list and says, oh, let's do your annual check. They're not doing that annual check because you've already told them there's a problem. You're doing your 1 yearly annual check to find out things before it becomes a problem. That is what screening is. So you're not screening when there's a problem. When there's a problem, you're diagnosing. And again, just to reiterate it, early cancer and risk factors detection, that is what we want here. Whether there's a cancer risk or whether there's even a risk factor risk. Then in cancer screening, some screenings are tests that you go and do, just like your mammogram, your pap smear, while some are examinations where I examine your breast. That's an examination. Or for the men, I do a rectal examination to feel the prostate. That's an examination, while others are actual investigations. Then, cancer screening varies by age, gender, risk factors, and all that. And the guidelines are usually explained by a healthcare professional. So just to say, sometimes people say to me, I don't know what screening I should do. The whole idea is that at a certain age and for a certain gender, there are guidelines. So let's take breast, for instance. If you're 40 and female, you should be doing your breast self-breast examination, annual general check with the doctor and all, and then your mammogram. So those are the kind of guidelines that the healthcare professional will be able to help you with. And that is what cancer screening is about. So there are 3 cancers that can be screened for in women: colorectal, cervical, and breast. And because, breast is always, talked about, I decided to tweak it a bit today. Rather than start with breast, let's start with the one that most people don't even know much about, colorectal, which we also call bowel or the large intestine. So this is a picture of your colorectal area. The colon and the rectum make up the colorectal area, and that's the large intestine or the large bowel. That's what it's also called. So this is it, this. And these areas, any of these areas can have a cancer, okay? And when it does, you now call it colorectal cancer or colon cancer or rectal cancer, depending. And, for the most part, the colon is the main part of that large intestine, while the rectum is the smaller part, just towards this end here. And they all have different roles. The colon absorbs the water and nutrients from the waste. Just before that waste then goes into the rectum, and the rectum carries that waste until you have the urge to go and expulse it, go to the toilet and let it out through the anus. And now, around this whole area, you can form polyps, like little growths. Not all polyps are cancerous, but polyps can have the potential to become cancerous. And so when we talk about screening for the colorectal, the gold standard is what we call the colonoscopy. The colonoscopy is the camera that is put through the anus, and it goes all the way around. So it goes through the anus and it's going round, this whole, length of the large gut. It's not done under general anesthesia. You're awake, you're chatting with the endoscopist, they are showing you the pictures on the screen, they're asking you questions, you're not in pain. It's done under very slight sedation. You have a bowel preparation prior to it, like 48 hours, so that the whole gut is cleared of feces and the doctor can actually see what they're doing. It's like taking pictures. Now, if the doctor sees a polyp, they take it out. They must remove the polyp. Good endoscopists do not mind spending an hour taking out every polyp they see. And when they take that polyp, they send this polyp to the pathology lab to check if there are any cancer cells there. So that's the whole idea of the colonoscopy. It's the gold standard because you can see and you can take. Now, there are other tests that can be done for colorectal cancer screening, but they are not gold standard. So one of the ones we also do at our facility is the FIT, fecal immunochemical test, or the GFOBT. It's a stool test. All it does is it checks for the presence of blood in the stool. It doesn't tell you it's a cancer because there are other conditions that can cause blood to be in the stool. Even eating beetroot, we actually tell you do not eat beetroot before this test because we can detect beetroot and it can mimic blood. So you can see that this is not a gold standard test, but it's a good one to do while for different reasons, if you're just trying to raise your funds for the colonoscopy, or if you have done the colonoscopy is every 10 years. If you have a normal result, you don't have to do it again for another 10 years. And in between, you can do the FIT or the GFOBT. So the others are flexible sigmoidoscopy, CT, but they are less, they are not really the first choice for cancer screening. The cancer age for screening has started reducing because of the incidence of colorectal cancer is rising. About 15, 20 years ago, cancer screening globally was 50 years. By the time I came back to Nigeria, the American Cancer Society, Colorectal Society, now said it was 45 years because they were having more incidents. And now it's 40 years. Especially, this incident is in the Black community. Even in Nigeria, we have now seen that incidence, it's rising amongst our younger people. So going back to what our young people are eating, this is a problem. One of the earliest young people we had in our facility with colorectal cancer was 26, I remember. But thank God, 10 years down the line, he is cancer-free, he's alive, just got married, and, he's one of the rare cases because he came at a stage 4. So that is very unusual. But the point I'm making here is that the cancer rate is rising because the diet is poor. The diet is very poor. So if you have young people in the house, I have a 22-year-old in this house and an 18-year-old. And as much as they love their vegetables, they love their protein, but, this is the age they're living. So if you give them half an inch, they will just, pick other things. So I'm always sort of preaching and saying, listen, you must keep your gut healthy by eating a balanced meal. So please take this message to your young adults and your young people. And now the screening age is 40. We do 40 at Lakeshore Cancer Center. We don't even do 45. 40, we start talking to people about screening. And this continues until 75 years of age. So that's for colorectal cancer screening. Then for cervical cancer screening, I saw this and I really liked it because it just highlighted a couple of things very quick when you eyeball it, things that are very key for cervical cancer. Whether it's the pap smear, the high-risk HPV, the vaccine, the provider testing, the prevention. It has all the right words here that we should all know, the, virus. And so, like I mentioned, cervical cancer and HPV screening fact. HPV is a virus, human papilloma virus, and is the cause of 99% of cervical cancer. You have the 1%, which would then be those risk factors we talked about earlier. So whether it's the smoking, sedentary life, poor diet, it increases your risk of all cancers. But for cervical cancer, the main thing is this virus, HPV virus, which is really why I'm still a bit perplexed about the whole hullabaloo around getting vaccinated. This is the cause. I don't think anybody can doubt that HPV is the cause of cervical cancer. 80% of us women who are sexually active have been exposed to HPV at one point or the other. To clarify, as much as you can get HPV from sexual intercourse, it's not really in the category of the other STDs like the chlamydia, gonorrhea, because the body can clear this. So most of us do not even know we've been exposed to HPV. You can even get it from sharing towels. So always keep your own towels, use your own towels, use your own face towels, use your own towels. Do not share towels. It's as easy as that. And 80% of us will get it as we're sexually active, even when you're sexually active with one partner. That's also the difference. And your immune system, as far as it's robust, will clear it, just like any virus. We're exposed to viruses all the time, whether it's a cold virus or gastroenteritis, you have diarrhea, and everybody ate the same thing as you, but they didn't have it, so it's not food. It's a virus. We get it. But with HPV, most people will clear it, but some people will not clear it for some reason. Either your immune system is impaired most of the time, and then it stays there, causing changes in your cervix. And those changes can then lead to cancer. And that's the whole idea about screening, so that you can pick up those changes in the cervix early and treat it. And we now have screening, not just with the pap smear. We don't even do traditional pap smear anymore in our facility. We do what's called the liquid-based cytology. It just it's the same collection method, but just slight preservation. And we do the HPV DNA test. In fact, in some countries, they don't really do the pap smear and the LBC. They do the HPV DNA test. When it's negative, there's nothing, then that's it. they don't go ahead to do the LBC. But if they do it and it's positive, it shows that there are some HPV viruses there, they'll call you and finish up and do the LBC or pap smear. So these are very important. And the sad thing is that if you have HPV persisting inside the cervix, it actually takes about 5 to 7 years before it actually becomes a full-blown cancer. And so in that 5 to 7 years, screening is every 3 years minimum, or every 5 years. The honest truth is you could have picked up the abnormality at least once or twice during your screening before it became a cancer. So again, screening is very important. And for cervical cancer, it's every 3 to 5 years, starting from the ages of 21 to 65. Some countries start at 25, while some countries say, because our girls are more sexually active earlier than previously, we now say add 3 years to your age of first sexual activity, and that is when you should actually start cervical screening. In other words, if you've had sex at the age of 15, rather than going with this age of 21, you can actually start having your cervical screening at 18. So this is why for some, I always say when people come to talk about screening, it's better you discuss screening with your doctor, because there are some questions that will be asked, which means that your own screening is very customized. It's tailored to you. So if I have a young person come to me, for instance, and they are 23, and they say to me, and I ask them, oh, you want to do your cervical screening? At what age did you have sexual intercourse? And they say, oh, I had sexual intercourse at 14. I had 3 years, 17. That person should already have started screening years before. And again, there's vaccination with the HPV. We've gone through different brands of the vaccine, but currently what we have is called the Gardasil. And there are 2 types, Gardasil 4, which covers about 4 subtypes of the HPV, and Gardasil 9. Gardasil 9 is very expensive, and most people can't really afford it. So we always say Gardasil 4. The good thing about the Gardasil is that it has a wider range than what we used to use some years before. Severix, if some of you remember who have had this vaccine, Severix only covered 2 subtypes, and it was specific to subtypes 16 and 18 for cervical cancer. But what we now know about the HPV is that it doesn't just cause cervical cancer, it causes anal cancer, oral cancer, throat cancer, tongue cancer, because of the different modes of sex. So it's not everyone who has vaginal sex. There are people who do anal, oral, and this HPV is transmitted to all those parts of the body. And so the Gardasil has expanded the subtype, meaning that it's not just for cervical cancer, it's for those other cancers. And it's not just for girls, it's also for girls and boys. So, for instance, using my own example, my son was in a school and they gave vaccine to both the girls and the boys. So, vaccine can be given to both boys and girls. And you can get the vaccine right up to the age of 45 with the Gardasil. But again, be guided by your doctor. Risk reduction, safe sex, no smoking, and a healthy diet. By the time you have symptoms of cervical cancer, the disease is advanced, bleeding, discharge, and pelvic pain. That is where we don't want to be. And then breast cancer. We have these, we have some of these flyers that we can actually send across, to you, and we can get the soft copy and maybe have Biola share it. It just teaches you how to examine your breast yourself. Breast cancer screening starts with what you do to your breast yourself. So every month after your period, if you still have periods, you must examine your breast, your axilla, really touch, go around, squeeze the nipples, check the armpits. And then if you don't have periods, every month, just select a day in the month and do your breast check. The fact that I'm saying once a month doesn't mean you can't do it as often as possible. Basically, this is showing you the shower one, which I do a lot. You know, when you're in the shower and you're cleaning yourself, you do your, some examination. Then you have the mirror one, where you stand in front of the mirror and the mirror is showing you your breast, whether it's symmetrical, whether the nipples are the same, you're visualizing. Because for most women, when you bend, you don't actually see all corners of your breast unless you're lifting up. So the mirror helps you to reflect. Then you have when you're lying down, you check it again. And please, for those who have partners, husbands, tell them, teach them so that they can also check when, you're in bed. Because some of the patients we've had at Lakeshore with breast cancer, their husbands actually found the lump. So please engage your partners as well to be involved in this process. So breast cancer screening, self-breast examination, like I've said, monthly, post-period. Clinical breast examination is when you come once a year to a facility that is geared to this. It's not every doctor or nurse who is into screening. So please don't assume that when the HMO sends you off somewhere, that the doctors and the nurses there actually know about screening. You have to be intentional to go where they do screening. So they will check it and also check your technique. Make sure that you have been doing it all right. That's once a year. And then once a year, from the age of 40, you start doing the mammogram, which is the gold standard investigation for women 40 and above. It's a low-dose X-ray, which checks the breast and the armpit really well, beyond what you can feel. And when you're checking, what are you looking at? I think most people have it in their mind that it's always lump. No, there are people who have never had a lump and they have breast cancer. My friend went to work and then she used to work in a bank. And some, the bank smart dressing, you wear your shirt and then you have your blazer on top and all. And somebody said to her, "Oh, your shirt is actually stained." And so she went to the toilet and checked, and she had blood oozing from the nipple. And she had never felt a lump. So she went to her doctors, and within 2 weeks, she was diagnosed with breast cancer. She didn't have a lump. It was in the duct. So you cannot feel that. And the whole idea, though, the reason I'm mentioning this is that when you're doing your breast examination, you're not just feeling for lumps. You're looking as well. You're looking for skin changes, breast changes. Is one breast suddenly bigger than the other? Is it asymmetrical? Do I have a sore on the breast that hasn't healed? You've got a clotrimazole canister rubbed. You've got a dusting powder rubbed. You've got, and the sore is still there. You have to have it checked out. Then you check your nipples as well. Suddenly, your nipples that are inverted, most people have inverted nipples, meaning that they are out. Some people by birth have inverted, meaning they are in, but they are both inverted. So if suddenly your nipples that usually both of them would be inverted, suddenly one becomes inverted, that's also a concern. You have to. So these are the things you need to check out. Then pain. Traditionally, breast lumps actually don't come with pain, but we always say to people, anything unusual happening in that breast, please go to a doctor and have it checked out. Then for cancer screening, things like family history and genetic risk, as mentioned, is very important. So I've said that the mammogram is from age of 40, but actually if you come to me in your 30s and you tell me that your mother had breast cancer and your grandmother or your mom's sister, your mammogram is going to be starting early in your 30s. I won't wait till 40. So these are the conversations you need to have with the doctor. And that's why I keep saying your screening should not just be driven by the HMO, the list they give you. Ask to see a doctor, have a conversation, discuss what is personal to you. That is how you will go for your screening. Breast ultrasound, again, this is something the HMOs are doing. It's all part of the money. They just put in breast ultrasound, and you find women 40 and above going for breast ultrasound. But actually, breast ultrasound is not a screening method. It is not recognized to be a screening method. It's a diagnostic method. So if I go for my breast mammogram right now, because the mammogram detects that my breasts are a bit dense, dense means that I have more glandular tissue, so the mammogram might not be seeing everything it wants to. So for the sake of completeness, it needs another imaging method to see everything. They will send me off to go and have an ultrasound. That is the role of ultrasound. Or when you do a medical outreach, so for instance, I come to ICOC women and you have an outreach, and I find some young people who have some lumps, I will say, and they're under 40, 20 something, 30 something, I will send them to go and have a breast ultrasound. Diagnostic. It is not a recognized screening method. So please, if you're 40 and you work for a company and the HMO sends you off to go and do a breast ultrasound, put your foot down and ask for a mammogram. And men can get breast cancer too. Men who get breast cancer are sort of linked to a family history. You have a cancer syndrome. Some families where the BRCA testing, the gene testing, means that the men have the gene and they can also get breast cancer. They won't check their breast traditionally the way we do because theirs is in the chest wall, kind of. But it's always usually aggressive. And so, final last word. I don't know if I've done my 30 minutes I've run through, but I'm almost done. Cancer screening is a lifesaver. Let's reverse the whole cancer is a death sentence. No more. We don't use that anymore. Cancer is not a death sentence. Cancer screening is a lifesaver, which means that cancer is not a death sentence. Early detection is key. Screening is your best option. Screening, please. Screening. Don't wait for symptoms. Take control of your health, not just the HMO. The HMO is not controlling your health. You are controlling your health. You tell your companies, you tell your HMOs what you want because you have been educated, you have the information. And the most important element is joining with your doctor. Please, if you do not have a doctor that you're registered with, please register with a doctor. A doctor who knows you and you develop a rapport and relationship, a doctor who is accountable to you, a doctor who becomes the repository of all your tests and results. You can come in. Sometimes I'm thinking, oh my gosh, when did I do my mammogram? Was it last year? I don't know if it happens to anyone. Was it last year I did my cervical screening, or was it? I go to my doctor, I'm like, Dr. Mams, check the records. We check. Oh, no, okay, I'm fine. I just had it. Because you have a lot on your head. Your doctor is accountable. They have your records. You know, sometimes people will send the results and say, can you tell me? I'll just say, okay, hold on. When I get to the clinic, I'll open up your records and I do a comparison and I can advise you. But this whole idea you don't have a doctor, once you're in your 30s, you should actually, everyone, even children, should be registered. Families should register with a doctor and have a family practice that you go to. That way, when it comes to screening, you and your doctor are talking about, by then, your doctor is even saying to you, you know, you told me the other day, your mom's sister just had a diagnosis, and I know from your records, you told me that your mom has this, the same thing. I think we need to talk, book an appointment and come and see me. And immediately, your screening journey changes because your doctor knows you. So please, if you're not registered with a doctor, let me just say it again, find a practice and register with a doctor. Don't wait until you're ill and the HMO starts looking around for a hospital to send you. Already be registered with a doctor and check if your practice is registered with the same HMO. You know, I'll tell you the truth. I did something very, my HMO is through my work, but I'm registered somewhere else for my family, all of us. And I asked them, is your HMO, do you have this, my HMO in your book? And they said, no, we haven't registered this HMO. I said, so do you mean that when I come to you, I will pay out of pocket. It's not happening. I'm already paying for HMO. I told them, see the officer for this HMO. Take it, go to them, tell them to register you. I was intentional. And so today, my own family practice where I seek my health, my family has my HMO. And they have registered other HMOs. So the whole idea is for your family practice to at least have diverse HMOs that makes it accessible for people to be able to access care there. And then self-care is not selfish, please. Prioritize you. Women, you know what we're talking about here. I see women booking appointments for their husbands, coming with children for their appointments, and I'm asking them, when are you coming for your annual check? I'm going to come very soon. When I come back, okay? And then 2 years goes by. That woman hasn't had her annual check. Then another day she turns up. She has booked an appointment again for somebody, or her mom or her father is visiting. Oh, doctor, I'm going to bring my mom and my dad for their health check. They are leaving Lagos very soon. I don't want them to go without their health check. That woman has still not had her health check. This is a familiar story, right? And then the other part of it is, oh, this screening, I'm sure they are expensive. But then you're telling me that you're going to buy a Shebio to go to Obomosho for wine carrying. The screening tests are cheaper than that Ashebi you bought, and I'm not exaggerating. And I'll lay it on the table here. The most cancer screening here is the colonoscopy because it's actually a procedure. Every other thing here is affordable, whether it's through your HMO or out of pocket if you have to do it. And the good thing is that some of them is once a year or once in 2 years, or like the colonoscopy I talked about, it's every 10 years. So it's intentional. Self-care is not selfish. You need to prioritize yourself. Thank you. Any questions?
Thank you very, very much. Wow. When we were scheduling time, she was like, no, not so much time. But when you talk about something so passionately, she kept just going on and on. I couldn't get a grip of her. Thank you so much for speaking to us very passionately, ma. So because we have run out of time, I will please, ma'am, I would read the questions that have been dropped in the chats. Please give us a succinct answer as short as possible because we still have other things to run through. Okay, so this first question is it advisable to do mammogram after having done lump remove? After having done lump removed, is it also advisable for a girl who is not sexually active to do cervical tests?
Okay, so very quickly, I'm not sure thank you very much for the questions. I'm not sure I understand the question about doing mammogram after a lump is removed. All I can say is, if a lump is removed, the doctor needs to tell you what that lump is. Is it benign? Because you have benign lumps. Not everything is cancer. And subsequently, after you've healed, when next your mammogram is due, you should have it done. So it doesn't affect, yeah. And then is it a girl who is not sexually active to do cervical test? Not really. If the child is not active, all you can do is at least get them vaccinated. So you don't have to. I think there are some other questions. Do you want me to run through those ones very quickly?
If you can, man, so that we can do that quickly.
Yeah.
Thank you.
So with osteoporosis, which is a huge major topic, I just mentioned it there. Speak with your doctor a bit more about your risk of osteoporosis, but yes, you can take multivitamins, vitamin D, vitamin C, but you must have a diagnosis of, osteoporosis. What time is early detection? Since research says cancer stays 80% of their life cycle in the host body undetectable. I'm not familiar with this information, so I will pass on this. Early detection is as early as you can using the guidelines mentioned, age-specific and gender-specific. That is when you start. Please, doctor, is there vaccination against breast cancer? No. For cervical cancer, no. And how often do you screen for breast and cervical cancers? Again, like mentioned, for women, as soon as you have breast, please start examining your breast. So if you have young girls in the house, your daughters, teach them how to examine their breast. And then once they get to mid-30s, they start having their annual checks, and then 40, they start having the mammogram. And for cervical cancer, like I explained earlier, once you're sexually active, add 3 years to it, and you start doing your cervical cancer. But the standard age is 21 to 65 years. At what age can you go for the cervical cancer vaccines? From the age of 9 years. It's actually targeting school-age children, because the assumption is that the earlier you give the vaccine before they are sexually active, the better. They've built up the immunity, the antibodies. But now, these young ones are also becoming sexually active, even young, age of 9 years. What is the range of amounts of mammogram? It varies. There are many different diagnostics and facilities, but I would say with the mammogram, out of pockets, if you go and you're paying and not the HMO, it's a range between 20,000 and 50,000. So it's a range depending on the facility. I had a mammogram done and was advised to do a breast scan and biopsy. But when I got to the hospital, they did not see anything. What do you advise? If it's a doctor that is your doctor, they would usually give you a timeline and tell you, okay, come back in 6 months, or normal screening, do it again in a year. So without having your clinical details, I can't actually advise, but I would suggest you go back to the doctor and pin them down on what the next step is for you. Thank you. Okay.
Thank you so very much, Ma. We are grateful. For our other concerns, I am going to share the number for Lakeshore Cancer Center. I just did in our chat box. Please reach out to them personally. For lack of time, we would not be able to take other questions. We apologize for that. So quickly, we are going to have our second session run through us by Dr. Funmi Aina, who is a medical and independent consultant in health and child public. She's a seasoned medical doctor with over 4 decades of professional experience. She holds a postgraduate diploma in tropical child health and hospital management, as well as a master's degree in child public health. Her career in public service included the establishment and leadership of child health unit within the governmental parastatal. Well, she's a founder and managing consultant of Funmi Health Consultant. Her profile goes on and on and on. She's a devoted mother, a grandmother, and has been committed as a follower of Christ for over 34 years. Please welcome with me, if you can, Dr. Funmi Aina, as she takes the stage. Please, Ma, you have 30 minutes to run through your session. Thank you, Ma. We cannot hear you, Ma. You are muted.
I'm so sorry. Good morning, everybody. My dear sisters, thank you for the privilege of being asked to talk to us today. And, before I move on, I want to thank Dr. Ilegbune greatly for the very extensive and valuable talk on cancer screening. Even before I go into my own talk, just to say that I so agree that in Nigeria, we have to be intentional about our health. I have the privilege of having association with the National Health Service in the UK. And, you're sort of taken care of by the government. You get letters. I know when I get to the UK in December, I'm going to get letters for this, screen for this and that. But in our own situation here, we have to really be intentional and make it a priority. I do hope that one day there'll be a time where the health service generally will capture everybody and people will get letters and notifications that you need to do this, you need to do that. But anyway, that's what it is. And that's why I believe the talk from Dr. Ilegbune is so valuable. It has even raised certain things in my own psyche for myself. So let me share my slide, start to share my slide before I go on. Okay. Okay, thank you. And my talk today is simply titled Thriving Through Menopause, What Every Woman Should Know. You know, every woman is going to go through menopause if we live long enough. We're going to get through menopause. And so it's very important that about it. And it not only affects us as women, menopause affects our families and even our workplace. And it's found that statistics show that 30.4 to 52.7 women will experience severe menopausal symptoms. And that's why it's important that we know about it, we're comfortable talking about it, and we know what we can do, you know, to help ourselves. Many women feel unprepared, you know, for menopause, and this leads to confusion, unnecessary suffering. And, you know, because there's a stigma, many people suffer in silence. We don't talk about, you know, these menopausal symptoms as much as we need to talk about them. And that is why such a discussion as this is really important. And then there are different myths around menopause. And these myths lead to fear, and there's misinformation. And so that's another reason why it's quite important to have discussions like this. You know, sometimes a talk like this will be a reminder, you know, but, you know, as many reminders as possible are important, because sometimes we know, we say we know it, but there's a quote that says, if you know and you don't do, it's like not knowing. And so we can never get enough of health talks like this. When we have the right information, the right knowledge, and we take timely action, instead of suffering through menopause, we can thrive through it. Now is menopause. Menopause is the natural end of menstrual cycles. It's natural. It's what will happen. It's not a disease, woman. And we need to embrace it, because for a woman to go through menopause or get to menopause, let me put it that way, it means she has lived long enough. And so it's something we need to embrace. And menopause is confirmed after 12 consecutive months without a period. And that's in the absence of any other medical cause, like any disease or being on certain medication. That, and a woman has not had a period, been said to be in menopause. Now we have the transition phase, which is perimenopausal. And the symptoms of menopause may last several years. I know women who they've achieved menopause, they attained menopause 10 years ago, and they're still having some of the symptoms. So it's really important for us to know this. But I'm going to talk about the perimenopause. It's the body's gradual transition towards menopause. Again, I say it's a normal, natural stage of life. Usually begins between 40 and 50 years, but it can start much earlier. There are women that get into, start experiencing perimenopause in their 30s. But you see, when it's under 40, we talk about premature menopause. And what happens at this time is, excuse me, please, can you give me a minute? I'm sorry for that interruption. So yes, at that time, the levels of the female reproductive hormones, especially estrogen, they start to fluctuate. They rise and fall unpredictably, and these lead to those symptoms. Periods may become irregular. It could be lighter, heavier. They could be closer together and further apart. Normally, a woman would have a 28-day cycle, and they could get shorter than that, maybe for 3 to 5 days, but they could get shorter than that or even longer than that. But this period, this stage ends when the woman has had 12 consecutive months without a period. Sometimes a woman could go through 3 months without a period, and then the period comes again, and then you're still in pre-menopause. Sorry, just a minute. Yes, so the menopause is not a phase. It's a one-time point in time. It's a date, and that is the 12-month mark when without a period. It marks the end of ovulation and natural fertility. The ovaries at this time have significantly reduced hormone production, and the average age that menopause happens is 51 years. Again, it varies from woman to woman. It could be later and it could be earlier. Post-menopause is a woman's life after the period stops. And again, it begins at menopause, at that 12-month mark without a period, and continues for the rest of a woman's life. And at this time, long-term health considerations become more important. And I'm going to talk about them shortly. Now, in menopause, the estrogen, post-menopause, the estrogens remain low. So certain symptoms of perimenopause may continue. Hot flashes may lessen or continue. Vaginal dryness, there's vaginal dryness and thinning of vaginal tissues. That's called vaginal atrophy. And at this time, women may experience discomfort during sex. The symptoms in perimenopause, we have hot flashes or night sweat. You suddenly you feel hot. Some women, it's in their faces. The face suddenly becomes hot and then it cools down. Some women, it's their hands and feet that suddenly start sweating. Then we have breast tenderness in some women called mastalgia. At this time, the periods are irregular. And this time also, we have mood changes. If women become irritable, become anxious, and we have low moments. You know, at this point, the families also suffer. I mean, the families are impacted, let me put it that way. When the woman suddenly, maybe the mom suddenly gets more irritable with her children, with her husband, and then women experience poor sleep at this time. Now, in perimenopause, fertility is decreased, but pregnancy is still possible. Why? Because the ovulation is irregular, but it's not totally absent. So women in perimenopause can still get pregnant. So if you're a woman who, does not want to get pregnant, it's a time to to see your doctor and have a form of family planning. I'm sorry, where I am, I don't have control over power, and power suddenly went off. So you please bear with me. You may not be able to see my face properly. Typically, perimenopause lasts 4 to 8 years, but again, it varies. Around menopause, we have weight gain or increased tummy fat. At this time, a woman can have brain fog, forgetfulness, joint pains, vaginal dryness, like I said, and discomfort during sex. In postmenopause, women can have urinary symptoms, urgency, frequency, you pass urine frequently, and you can be more prone to infections, urinary tract infections. Again, we talk about sleep disturbances. While some women have low libido, others feel sexually better, but without the cyclical related symptoms. Now, at this time, we have the long-term health considerations. Dr. Ilegbune talked at length about osteoporosis, when the bones are thinning, and women are prone to fractures, spontaneous fractures sometimes, and sometimes it may be a little, a fall or some trauma that normally would not cause a fracture, but a woman with osteoporosis may experience a fracture at that stage, and that may be the first sign of osteoporosis. Again, at this time, a woman is more prone to heart disease. Possible weight gain and because of slower metabolism happens at this time. Now, this may or may not be, it's not guaranteed, but those are conditions that happen in post-menopause. Now, how do we manage? What are the options of managing menopause? There are different options. We have healthy lifestyle and complementary approaches. We have non-hormonal treatment, and we also have hormone replacement therapy. Now, in terms of lifestyle, just like Dr. Ilegbune has talked about, lifestyle is important. The importance of our lifestyle choices, our lifestyle modifications, they span, the value spans every aspect of life. Where I am now, we're doing some screenings and health talks, and for in prevention of any condition, really, our lifestyle is very important. We cannot talk about it enough until we are doing everything we can do, everything we know to do to prioritize our health, the choices we can make. We have not heard it enough. Regular exercise is very important. It helps with hot flashes, mood, and sleep. And what is regular exercise? I often say that if you cannot, if what is not counted cannot be improved on. And there are different forms of exercise that we can do. But the most basic is keeping active. Brisk walking is recommended for an individual to have 30 minutes, at least 30 minutes of brisk walking on most days of the week, at least 5 days of the week, at least. And that comes to like almost 2,500 to about 3,000 steps. I know that many of us are health conscious. We have pedometers, because if we're not intentional, it'll be difficult to improve it, to be consistent with it. So regular exercise is very, very important. Now, we also talk of in prevention of osteoporosis, we may not limit it to just walking. There's strength training, weight training with weights. I mean, talking about those it could be a full lecture in themselves, but it's important for us to know that regular exercise can help. And even before some of us may be in the perimenopausal phase. Some of us may not yet have reached there. But what it is that beginning to prioritize your health in the area of these lifestyle choices, the earlier we start, the better. There are several studies that have shown that the value, if a woman starts or a young lady starts prioritizing these health, these lifestyle choices younger, they reduce the risk of developing a lot of these health conditions later. So it's never too early. And it's also not too late, because even there are studies that show that people who even start doing them in their 60s, they still gain value over people who do not do them at all, who have not started. Then balanced diets, rich in fruits, vegetables, whole grains, calcium. I know that we talk about eating fruits and vegetables. Again, it's important, I believe it's important to be intentional about that. It is recommended that we take 2 fruits and at least 3 portions of vegetables a day. I know these are things that we've heard. A lot of us, it's a reminder. But if we're reminded and it prompts us to take action, it's very important. There are fruits in season, different fruits in season. And personally, in the last few years, I started prioritizing, specifically and intentionally prioritizing diet, exercise. And I found that it helps to look at fruits in season, because that will be cheaper. And it also helps to know what is a portion of vegetables. If what is one is like 80 to 100 grams. So if we do this intentionally, it will help even as we approach menopause. And then limiting processed foods. I know that in years gone by, it used to be, what will I say, a status symbol to eat certain foods. Sausages, bacon, tinned food, sardines, corned beef. Really, these are processed foods. Whereas we are encouraged to eat whole foods, foods that are nearer to their natural stage, to their natural condition. More foods from the farm and less foods from the factory. Then limiting alcohol, caffeine, spicy foods, because these can trigger hot flashes. And stopping smoking. Please note that, just like Dr. Ilegbune said, women do smoke, and stopping smoking helps to reduce symptoms of menopausal symptoms. And it really improves our overall health. Limit alcohol. I mean, it is said that one unit of alcohol, one drink a day, is what we should aim for at the very maximum. But what is one drink a day? I had a talk yesterday, and I was saying a drink a day is not a glass of whiskey, half a glass, maybe 150 mils of wine is a drink. A 330 ml can of beer is a drink. A shot of whiskey is a drink. But again, it's not that it's fine to take those every day, but once in a while. Then maintaining a healthy weight. Again, because of the regular type of diet that we have in this environment, it makes a lot of people overweight. And we have to be intentional about it, because these are some of the lifestyle choices that will help, not just in helping us to combat the symptoms of menopause, but overall health generally. Then we have complementary approaches to managing menopause. There's cognitive behavioral therapy. It's a kind of psychotherapy where the doctor helps the individual to, helps the mind to focus on positive things. I mean, there's a lot involved, but it helps the mood and helps sleep in menopause. Then breathing exercises, some people do yoga. There are some herbal supplements that have been said to help in menopausal symptoms, but one needs to discuss with your clinician, because the evidence, even though a lot of people actually swear by them, and I believe they do work, but the clinical evidence is not strong, and it's important to discuss with your doctor before you take them and while you're taking them. Then we have non-hormonal medications. We have certain antidepressants used in a low dose that can reduce the hot flashes, and then other medications. I mean, the details of these, when you see your doctor, what management option for you will be that is best for you will be worked out. Then short-term medications for sleep can be prescribed. Then we have drugs like gabapentin or clonidine that help with night sweat. Now, hormone replacement therapy. Here, the small amounts of hormone, mainly estrogen, are given. They're given back because these drop after menopause. Now, this helps to relieve hot flashes, night sweats, mood changes. It improves vaginal dryness and protects bone health. It includes estrogen, sometimes progesterone. When a woman still has a womb, she hasn't had a hysterectomy, progesterone is also given. But it's not everybody that is eligible for hormone replacement therapy. Again, your eligibility will be assessed by your doctor before offering you that. The hormone replacement therapy comes in different forms: tablets, patches, gels, vaginal treatment. It's safe for many women, but it needs doctor's assessment. And like I said, it's effective for hot flashes and night sweat and helps with vaginal dryness. So what are the concerns? What are the eligibility? What's the eligibility for hormone replacement therapy? Women with moderate to severe symptoms, their quality of life, and their quality of life is affected, are those who benefit mostly from HRT and hormone replacement therapy. Women who are under 60 and are within 10 years of menopause and are generally healthy are those who would normally be offered HRT. Again, it's not suitable for women who have a history of breast cancer. Apologies, I have some error there. Yes, or blood clots or uncontrolled hypertension. So you can see that, like was shared, you have a doctor who has your history, who knows what has been going on with you for the past few years. That's the person, that's the doctor that can know whether you are eligible for hormone replacement therapy. And it needs to be given at the lowest, most effective dose. Now, in the consideration with hormone replacement therapy, it needs regular doctor follow-up for obvious reasons. So it's not something you take and you just go off and not see your doctor. Now, as I round up this talk, menopause is a normal phase of life. It's the transition. But menopause is actual menopause is the final period. So menopause is not a continuum. It is that final period. And post-menopause is everything after that. The symptoms can vary. Some people have no symptoms, hardly any symptoms. I think I was privileged to be one of those. But none of them is right. It's not, it's wrong to have many severe symptoms. It's right to have no symptoms. Symptoms vary from woman to woman. And many treatments exist. We should not suffer through menopause. Non-hormonal options, lifestyle. But I want to say that it's very important to start with lifestyle options, even when you haven't gotten to that stage, to prepare yourself. With this knowledge, I believe that we will not just survive through menopause, but we can definitely thrive through menopause. Thank you very much for listening.
Thank you so much. Can we please share our reactions with claps as we say a huge thank you to Dr. Aina? So quickly, again, we have run out of time because I think we really need a longer session to really talk and deliberate more on this matter. As I implore the church to please maybe give us one long Saturday to just keep talking and talking because we need it. We need it to help ourselves. So again, I would share Dr. Aina's number that we can reach out on, but please, it has to be via WhatsApp messages. So quickly, we would run through a few questions. Ma'am, if you can read them and just give us short answers to each of them, or if you would want me to help, or if you can, that's fine.
Okay, I have not seen.
We can start with, in the general charts, we can start with, okay, the first question, have you seen, ma'am, or I should read it out?
Yeah, okay.
Okay, the first question here says, can the type of family planning make one experience early menopause? And then cannot seeing menopause for a long time, like 7 years, affect your body or your hormones?
Not seeing menses for 7 years.
Yes, ma'am.
Okay, thank you for that question. Can the type of family planning make one experience menopause early? I don't believe so. I believe that menopause will happen when it will happen. And can not seeing menses for a long time, like 7 years, affect the body or hormone? For one not seeing menses for 7 years, the person is, I believe, already in menopause. Now, maybe it's premature. I don't know what the age of this person is, but it's likely that a person who is not seeing their menses for 7 years and is not on medication that will prevent it and is not sick has probably already reached menopause. And when you say, can it affect the body? Well, the symptoms of the menopausal symptoms, which are symptoms brought about as the female reproductive hormones decline, are the symptoms that the person would have. I don't know if that answers
okay.
Does
hormone reduction increase sugar in the body? And also, how do we read vaginal dryness in sex? What supplements are appropriate for 50+ women? That's 3 in 1, ma.
Okay, thank you. I'll start with the vaginal dryness. I mean, vaginal dryness is one of the very common symptoms of menopause. And there are different preparations that are given. So there are creams, there are lubricants. Simply there are lubricants that are given that can help. But at the extreme of it, hormone replacement therapy also reduces it. But there are lubricants, then there are creams, there are hormone creams that can be prescribed. There's a lubricant called KY jelly it's simple, that can be used. But if it's not effective and you are one of those considered for hormone replacement, there are other creams that can be used. Then, what supplements are appropriate for women age 50+? Well, there are different brands of supplements, and supplements that will help, like calcium, vitamin D, fish oils. It's more about the content than actually the name of the supplements. And there are some that have been formulated and they are 50+. So one would go for those. They're just different brands, but it's the content that one would look at. Does hormone reduction increase sugar in the body? When you say hormone reduction, okay, maybe the female reproductive hormones, one can be more prone, to diabetes, but they don't directly increase the sugar in the body. The metabolism it slows down and all that. But more importantly, if we keep to our diet, the right diet, that will help, to maintain a normal blood sugar. But of course, we need to check regularly for our fasting blood sugar, and then from there we can take action if for any reason our blood sugar starts going up, either to pre-diabetic level or diabetic level.
Thank you. Thank you so much, Ma. That would be all the questions we'll take today. We are grateful. Wow, like I said, it's been a whole lot of information. And if you did not get anything, please, from my little summary here, sleep deprivation, don't deprive yourself of sleep. Your nutrition is very important. Move your body. Let's not welcome a sedative lifestyle. Your weight is important. Shed off as much as you can. Family history. Please know your family history and know what you are prone to. And then go for screening, early detection. Going for screening is not like you're going to know what want to kill you. No, let's just know it so that we can take care of ourselves on time. And then again, self-care isn't selfish. Take care of yourself and prioritize especially women, we do so many matter for other people except for ourselves. And then register with a physician. Register with a doctor and let them be your repo of all your information. And talking about menopause also, you know, the different stages and how to thrive in them. Exercise is important also for us to do that. Your vitamins are important. Speak up, ask questions. You know, I've shared the WhatsApp number of Dr. Aina where we can reach her for private consultation. So thank you so very much again. Can we show our appreciation once again to our doctors in the house? Thank you very much, ma'am. Yeah. Okay, so because of course we are faith-based, we will definitely put this before God, who is our ultimate. We're going to have 2 minutes time praying individually, and then we will welcome Mrs. Okodua to give us another 2 minutes of prayer. Please spend the next 2 minutes talking to God about your health. Please surrender to Him as your Lord and Savior and beg Him that everything we have learned today, it would not just be one of those things and then fly off our minds. God should help us. Holy Spirit should remind us of the things we have learned and how to take care of our health. Let's appreciate God for where we are at as regards our health today and commit ourselves to Him. Let's also remember our sisters that are in some form of ailment at this time and beg God for His mercy, that God would have mercy on every one of them and for us too. Can we have Mrs. Opoduga close round off with a prayer, please?
All right, thank you very much. Before we round up, I would just want to call every woman here, you know, for as many people as we can mention, if you can just pray for them specifically, then I will close out. We have several of them. We have Keta Dioshun, we have Doye. I hope you can hear me. We have
Yes, ma'am, we
Doye,
can.
we have Grace Kayode. We have, you know, a lot of sisters or even brothers that are going through one health challenge or the other. So please commit them to God at this moment, then I'll take it up in 1 minute. Thank you. In Jesus' mighty name, we have prayed.
Amen.
The scriptures in Jeremiah chapter 30, verse 17 says, "But I will restore you to health and heal your wounds, declares the Lord." Dear Father in heaven, we're so thankful for this privilege that you've given to us to be enlightened, to be reminded, you know, to be taught, you know, on how we need to take care of our health. Because indeed, health is wealth. Because when we're strong, we can be our best for you. Father, we have heard so much. I pray at this point in time, just like your word says, that for everyone who is going through one health challenge or the other, that you please grant them healing. Father, you know them. There's several of them. And there's some of us that do not even know that we have one health challenge or the other. I pray, dear God, that you will help us, you know, to take to heart and take action based on the things that we have heard today. You know, that we will not just be hearers, but we'll be doers, that will make a decision, you know, to put into practice one thing so that we can enjoy the health that you have given to us. But I pray for all our brothers and sisters that are going through sickness. Please touch them. Please heal them. For some, we do need your help to provide the resources. Father, I pray that you will bless us so that we can support them. I also pray for some we're looking for where they can get the attention. I beg you, please, God, that you will guide us in wisdom, to where they can get the needed help that will, that they need, to be restored back to perfect health. Dear God in heaven, I also beg you, please, God, that you help, provide for each and every one of us, so that we will take care of ourselves. We will be intentional about what we eat, about how we rest, about everything that we have had, so that we will enjoy perfect health in your presence. Thank you so much for our sisters, who have taken their time out to share knowledge. I pray that you continue to bless them. I pray that you continue to give them strength. I pray, dear God Almighty, that you be with us as sisters. I know a lot of times we take so much time to support, to help people while we neglect ourselves. I beg you that we will not, put our own health to the background, but that, we'll balance it so that we will enjoy great health. Thank you so much for Jesus, who has given us the opportunity, to have this kind of time together as sisters and even to encourage one another. Please be with us for the rest of the day. Thank you so much for everything. In Jesus' mighty name I pray.
Amen.
Amen. Amen.
Amen.
Please we have
Amen.
Mrs.
Amen.
Abolawa give
Amen.
vote of
Amen.
thanks.
Thank you so much.
Amen.
Thank you so much.
Please, while Mrs. Abolawa gives the
Amen.
yes.
Myself. Thank you very much.
All right, sister.
Thanks, everyone.
Bye.
Mrs. Abolawa, we cannot hear you. I think she's been frozen. So we'll just take this time to say a very big thank you to the church for organizing this and also to our doctors. We are grateful. Thank you. And I hope that we will call you again and you will please answer us. So at
Thank
this time,
you.
we can unmute our mics, our videos to have a fellowship break before we log out. So we nice to see our faces.
Thank you so much,
Thank
Mrs. Scott.
you, everyone.
Thank you,
Thank you.
everyone.
Thank you so much.
Enjoy
Thank
the
you.
rest. Mrs. Oluwale,
God bless
Yes,
you.
one. Thank you.
Thank you so much.
Thank you.
please
Yes,
make use
Have
of
a
all that
wonderful
you have
service.
learned. Make
yes,
use of
Lord.
all that you
Yes,
have
I
learned.
do.
Thank you.
Yes.
God bless
The
you. Enjoy the
recording will
rest
be
of the
made
day.
available to
So
Bye.
us
you have a
through
great
our
weekend. Bye.
coordinators.
Bye.
Yes, thank you, ma'am. Bye.
Yeah, God
Bye,
bless. Bye,
everyone. Thank
everyone.
you.
Have a
Happy
great day.
birthday.
Bye,
Thanks everyone
everyone.
for joining.
Bye. Thank you, Mom. Bye.
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 Bye, everyone. Thank you
Thank
so much.
you.
Bye.
Thank you. Thank you.
Bye, everyone.
Bye, ma'am.
Bye. Bye. Thank you,
Bye.
Mrs. Selu. Thank you for putting it
So we
together.
sign.
Very enriching
Yeah.
class. God
Thank
bless
you,
you
ma'am.
guys. Thank you,
We
Biola.
sign out. You're welcome, ma. Thank you. We sign out in the next 3 seconds. 3,
Lovely weekend,
2,
everyone. Bye.
1. Love you all. Bye for now.